Anterior shoulder instability. This talk is focused on patients that have predominantly polar type 1 traumatic structural instability. If you'd like to know more about types of shoulder instability, visit my talk at Cambridge Shoulder on YouTube. When treating a patient with anterior instability, the epidemiology and natural history is of key importance in guiding management. A key study was undertaken by Hevelius in the late 1970s. They looked at a population of 300 patients in Sweden who underwent a first-time dislocation of their shoulder. None of these were treated, and they looked at what happened to them 2 years down the line. What they found is only a quarter of patients under the age of 22 hadn't redislocated, but 75% of patients over the age of 30 had remained stable. When assessing a patient with anterior instability, the age at the time of their first dislocation is one of the key factors to take into account. Also, the mechanism of injury of that first dislocation and any associated injuries at the time, subsequent dislocations and their mechanism, whether they've had any previous treatment, and also the dominance and their level of activity and their type of profession are also important. On examination, it may be difficult to assess a patient who's had an acute dislocation due to pain and discomfort. However, when looking at the patient, it's important to assess any asymmetry and scars, whether they have any pain over the anterior joint line. When looking at movement, you want to look at the range of motion, whether they have any apprehension and any associated scapular dyskinesia. Special tests will include looking for generalised laxity, instability and any problems with the rotator cuff, and also it's important to undertake a neurovascular assessment. A plain X-ray of the shoulder dislocated is useful, and on a modified lateral view, if available, it's sometimes possible to see evidence of a Hill-Sachs lesion and damage to the anterior glenoid. An AP view with the shoulder in internal rotation can sometimes highlight a Hill-Sachs deformity, and also any glenoid bone loss can be noted. This can sometimes be better appreciated with a Bogano modification of the axillary view. An MRI scan, particularly a T2 axial view, can highlight any soft tissue injury to the capsule and labrum and can sometimes also demonstrate a Hill-Sachs lesion. CT is the best modality to assess bone loss, and a 3D rendered view is useful for assessing the glenoid tract, which I'll mention later. Treatment for an acute traumatic first-time dislocator may differ from a recurrent dislocator. Examination of the acute dislocator can be limited due to discomfort and pain, but it's very important to assess the neurovascular status and also evidence of generalised laxity. Investigations are usually limited to pre- and post-reduction X-rays, as there won't be enough time to get an MRI or CT scan. Traditionally, the management of a first-time dislocator is for physiotherapy and rehabilitation. However, there are now some indications for a surgical stabilisation following a first dislocation. Robinson undertook a double-blind randomised control study of 88 patients under the age of 30 who are all first-time dislocators. They were randomised to have an arthroscopic lavage or a stabilisation. They all got their surgery within 2 weeks and had an identical rehabilitation. After a 2-year follow-up, they found the redislocation rate for the stabilisation group to be 7%, but 38% for the lavage group. They found that stabilisation gave a reduction in risk to redislocation of 76%, and to instability overall of 82%. Taking this into account, there are a group of high-level athletes, particularly involved in contact sports, who may consider undertaking an arthroscopic stabilisation after a first-time traumatic dislocation. However, it's important this surgery is done within 2 to 3 weeks of the dislocation. After this, the change in the healing soft tissues makes surgery difficult and can affect the outcome. The surgery is more challenging than a standard stabilisation, as there is often hemarthrosis. It requires less superior shift, but patients often have an ALPSA lesion. If you'd like to know more about stabilisations and acute first-time dislocators, go to my talk on Cambridge Shoulder. For patients who are recurrent anterior dislocators, the only treatment that's likely to stabilise their shoulder will be a surgical stabilisation. The choice of procedure is dependent on the amount of bone loss, which can be assessed on a CT or MRI scan, or at the time of diagnostic arthroscopy, and also on some associated factors. There is a threshold of anterior glenoid bone loss of about 20 to 25%, beyond which soft tissue stabilisation alone will be unable to stabilise the shoulder. This threshold may be decreased if there is an associated Hill-Sachs lesion that engages. The best way to assess bone loss preoperatively is with a CT scan, and with 3D rendering it's possible to visualise the bipolar bone loss and assess the glenoid tract. If you'd like to know more about the management of bone loss and how to assess the glenoid tract, go to my video on YouTube. Preoperative CT scans can only give assessment with regards to engagement. This is a diagnostic arthroscopy of a revision stabilisation. You can see how the Hill-Sachs lesion engages into the glenoid defect, exactly where the suture was placed. So probably this anterior stabilisation was always doomed to failure with this amount of bone loss. Boileau looked at a series of 131 patients who underwent an arthroscopic stabilisation and followed them up for an average of 31 months. They had a redislocation rate of 14.5%. However, when they retrospectively applied the Instability Severity Index score, which looks at the age of surgery, the degree of sport and level of participation, the type of preoperative sport, whether they had evidence of shoulder hypolaxity, whether a Hill-Sachs lesion or glenoid bone loss was present on the AP scan, they found that patients that had a score of 6 or less only had a 10% recurrence rate, whilst patients had a score of 6 or more had a 70% recurrence rate. For patients with a recurrent anterior instability with minimal bone loss, an arthroscopic stabilisation is generally a successful procedure, with 90 to 95% of the patients being stable 2 years after their surgery. If you'd like to know more about arthroscopic anterior stabilisations and the various techniques involved, go to my talks on YouTube. There is a particular variant of a Bankart tear which is known as an ALPSA lesion, an anterior labral periosteal sleeve avulsion. This occurs in patients that are skeletally immature. Rather than the capsular labrum tearing off, the periosteum is stripped off of the glenoid. As a result, the anterior labrum can heal more medially on the glenoid, and this can have issues with regards to successive surgery and should be taken into consideration. If you'd like to know more about surgery for an acute ALPSA lesion, go to my talk on Cambridge shoulder. For patients with a recurrent anterior instability and bone loss, the key to successful surgery is addressing the bone loss. Glenoid bone loss can normally be addressed by a bone plot procedure, either an Eden-Hibernate or a coracoid transfer, and Hill-Sachs lesion by remplissage or very occasionally osteochondral allograft. The principle of the Eden-Hibernate is that it extends the glenoid arc so that the Hill-Sachs lesion can no longer engage. If you'd like to know more about arthroscopic Eden-Hibernate, go to my talk on Cambridge shoulder. As well as extending the glenoid arc, a coracoid transfer also repositions the conjoint tendon to work as a dynamic sling. If you'd like to know more about arthroscopic and open lache procedures, go to my talks on Cambridge shoulder. For patients with a relatively small amount of anterior glenoid bone loss but a large Hill-Sachs lesion, another option is to undertake a soft tissue procedure anteriorly and to address the Hill-Sachs lesion with an infraspinatus remplissage. This will prevent the Hill-Sachs from engaging. If you'd like to know more about an arthroscopic remplissage, go to my talk on Cambridge shoulder. In summary, the key to management of a patient with anterior instability is the age at the time of their first dislocation, whether they've had any recurrence. When it comes to surgery, the key factors to take into account are bone loss and associated factors. If you'd like to know more about shoulder instability or any other aspects of shoulder surgery, go to my website cambridgeshoulder.co.uk.